Hello everyone, I'm Dr. Jack West, medical oncologist and founder and CEO of the Global Resource for Advancing Cancer Education, or GRACE. We're going to continue with the next part of our program on molecular markers in lung cancer, who to test and what to test for. I was joined in this program by Dr. Charlie Rudin at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University in Baltimore, Maryland. Also Dr. Alice Shaw, assistant professor and thoracic oncologist at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Also Dr. David Spiegel, thoracic oncologist and director of clinical research and the lung cancer program at the Sarah Cannon Cancer Center in Nashville, Tennessee. And finally, Dr. Glenwood, or Glenn Goss, the chair of the Lung Cancer Committee of the National Cancer Institute in Canada and professor at the University of Ottawa in Ontario, Canada. So, the current NCCN guidelines recommend ALK testing as well as EGFR mutation testing in patients with non-squamous non-small cell lung cancer. My question is, do we have any data to speak to other subtypes? And clearly the squamous is not zero. Does that mean that you think we should be testing patients with squamous histology and for large cell or neuroendocrine tumors? Is there anything really to speak to the frequency of these mutations that would lead to a recommendation by NCCN or any institution's policies?
Well, I think there are two parts to that. One has to do with this idea of only testing the non-squamous for EGFR and ALK, and the other question has to do with these other histologic types besides adeno and squamous. I think, as I showed you in that pie chart, there are a few percentage, small, but a few percentage of ALK-positive patients that have squamous histology. I would say in general, these patients tend to have a never or light smoking history, but they do have squamous histology, and that's confirmed by multiple pathologists that it truly is squamous histology. If there weren't this drug that can cause such an amazing response, you might say, well, maybe it's not worth looking for ALK and ROS and EGFR in patients when it's such a low percentage, but we have these drugs that can really transform a patient's disease course. So it's hard to imagine not screening at some point our patients, even with squamous histology. And in fact, at Mass General, we do screen everybody, even this squamous or non-adenocarcinoma patients, for ALK as well as ROS. Having said that, if we've already identified another more common mutation, such as KRAS, for example, which could happen in adenocarcinoma or even a squamous cell carcinoma, we wouldn't go on then to keep screening because we know these oncogenic drivers tend to be mutually exclusive. The other question about the non-adeno and non-squamous types of lung cancer is difficult to address because there's not enough data to really know how frequent these mutations are in the non-adeno, non-squamous types.
Yeah. You'd mentioned screening patients by serial, looking at KRAS and then looking at others. Is that something that folks on the panel are doing and advocating, or do you envision that we're going to be moving to a more multiplex single unit in time where you get a panel of greatest hits all at once? Obviously, there's some expense to that, but on the other hand, when you're limited by time and the amount of tissue available, I think that doing a series of tests is potentially a challenge. Or maybe we can get some thoughts from Dr. Spiegel or Dr. Goss on this about what your practices are and what you're seeing in the communities where you work.
I think it's a great question. I think we've moved away at our center, and again, I'm at a community-based program where we used to do sequential testing. You know, if you had somebody that was EGFR wild type, maybe it made more sense to then screen for EML4 ALK. But for the issues you raised, and really practical issues trying to get treatment to a patient, whether that's going to be on a trial or crizotinib or Tarceva or not, you're trying to make decisions in real time. And so now and I think it's pretty true for everyone, we try to do broad testing all at once. And then there are other issues we don't think about. So sometimes, it sounds crazy, but tissue gets lost in transition. So if you shepherd a material to one center and then think that that's going to where EGFR RAS testing will be done, but you need to send it somewhere else for EML4 ALK, at least that's the way it used to be. Sometimes that doesn't always happen seamlessly, and then that can add a week or 2 or 3 to getting results. And I don't think that's acceptable to any of us anymore, to wait that amount of time to get those results. I don't know, maybe Canada is a little different.
So in jurisdictions in Western Europe and in Canada where there are national health systems, there's a bit more of a tension around this issue between governments who are the suppliers of medical care and patients, obviously. Governments initially thought that they would be able to introduce one molecular test at a time But it has become obvious to governments that that's not necessarily the cheapest way to do it, because they're always looking for the most economical way to deliver healthcare, obviously. So I think to look for EGFR and then a few months later have to look for ALK, etc., rather than doing a panel of tests up front, it actually costs more if you do it in that way. So I think even Western governments have now been convinced that this multiplex testing, where we look at multiple genes and multiple abnormalities, is the way to go.
Yeah, I think the technology is really rapidly changing and is changing our approach to this. Clearly, one test where you do it in one tube and you get 10 results immediately is very attractive from the clinician's perspective and also economically feasible. I had one question for Alice. There's a significant fraction, certainly of American lung cancer patients are African American. You presented data for Caucasians and Asians. Maybe you just want to comment on African Americans and whether they cluster with Caucasian patients?
Yeah, I haven't looked at that closely. You may even know data better than I do, but in our population in Boston, unfortunately, it is very, like I said, Caucasian heavy.
In Baltimore, we have a lot of African Americans. Their spectrum tends to be very similar to Caucasians, at least in our experience.
Do we know for ALK in particular?
That's a good question. So I don't know that for particular.
And I think that's true in other types of cancer other than non-small cell lung cancer as well, that African Americans and Africans, for that matter, have a similar genetic profile to Caucasians when it comes to their tumors.
Hearing all this, it makes me wonder, does it even matter anymore what someone looks like or their smoking history? I mean, don't you guys think we're not far from every patient walking through the front door, male, female, Asian, non-Asian, is going to have this testing?
Well, that's
because of these needles in the haystack. I mean, to deny somebody a chance to get Xalkori, crizotinib, none of us would want that.
Well, I think that's interesting. This is, I think, a big struggle. To me, you have a drug like Tarceva or erlotinib that is FDA approved and well studied and has a survival benefit in a broad population. It's modest but meaningful, I would say, to most of us and to our patients to try it as a second or third line therapy. And if you have a mutation, it's clearly remarkably good for a lot of them. But you can give it to everybody as a second or third treatment anyway. But the Xalkori crizotinib model is different, and we're probably going to see more agents that are developed along the lines of available, but only for the 2 or 3 or 4% who have this. And then you would miss out on the opportunity to give a therapy that isn't just like ho-hum beneficial, but remarkably beneficial for that minority of people. So it really raises the ante of wanting to know. The problem, though, is that when you have to do a lot of expensive individual tests, it's pretty challenging, if not infeasible. If you can do a panel that is much more efficient financially on a broad platform, then I think you don't have to do as much individual selection by probability.
Yeah, I guess I might push back even a little, Jack, on the issue of erlotinib or Tarceva. I think a very informative study was a study that was published in the New England Journal a couple of years ago, which took patients with newly diagnosed lung cancer, Asian, light or never smokers, this population that we think is going to be very enriched for patients who are going to respond to Tarceva, and assigned them, though randomized them, to either chemotherapy or to an EGFR targeted inhibitor. And what was clear was if you had the mutation, you were likely to respond. And if you didn't, you were not likely to respond to erlotinib or gefitinib in that case, closely related drug. My take home from that study was really that we shouldn't be guessing. We should be looking for the mutation. And I think David's point that rather than looking at whether they're female or Asian and never smokers, that really the mutational profile.
I appreciate that. I would say, one, that there may still be a meaningful difference in the broader population between Tarceva and Iressa.
Absolutely.
I would bring up one concern that I do have, and that is, as Dr. Spiegel mentioned, it's not instantaneous to get these things sent out. It's certainly easier if it's done in your own pathology lab and can be sent from there. But if you're trying to coordinate getting tissue sent from another institution where you're doing a second opinion, there are a lot of moving parts, and it can be delays. And we have seen in certain studies that randomize between chemo and upfront EGFR inhibitor that the people who are not going to be beneficiaries of the EGFR inhibitor are potentially harmed from the delay in their best therapy. So I'm not sure it's trivial to postpone all therapy on everyone by 3 or 4 weeks, because a lot of people can deteriorate in that time. We haven't ever talked about it, but I do think that that's a concern.
I think that's a very important message to send out from this meeting, and that is, if you don't know any molecular markers, then it's better to get chemotherapy than a targeted agent. I think that was clear from the study that Dr. Rudin referred to, which is the IPASS study.
And the TORCH study done in Europe was a similar theme, basically an unselected population of European patients who were predominantly those unlikely to have an EGFR mutation. It was detrimental to guess wrong or to be randomized to a targeted therapy if you were not somebody likely to be a big winner with it. So I don't think that applies to second or third line therapy, and I think that's important to underscore that erlotinib Tarceva has been shown to be essentially equivalent to various other tested single agents. But in the first line setting, I do think there's a potential harm in waiting 3, 4, 5 weeks.
I mean, I'm assuming for each of you it's the same. Walking into a room with a new patient now, it's not as easy to make a decision. So many things come into mind in terms of not only do I have to get tissue off to test, but is this patient going to be able to wait to get those results back? Do I start chemotherapy? Is there a clinical trial I can get them on? I mean, it's a complicated process that requires a lot of thought. I support Glenn's comments about if you don't know, move on. But I think you want to take a thoughtful approach to every patient when you're thinking about all their options.
The other thing that we don't want to do is create anxiety, because most of these patients have been tested in the large, big academic institutions, both in the US and also outside of the US. And the vast majority of lung cancer patients are still not getting molecular testing, even in the US, who are probably the lead country in the world for molecular testing. So I think that you don't want to create anxiety. As we move along, it'll become more and more important to get molecular testing. But as your initial therapy, if you don't know what your molecular profile is, chemotherapy is a very reasonable alternative.
We've actually gotten a series of questions that have come in. One was really an implication of the Lung Cancer Mutation Consortium work, and that is, should our presumption be that most adenocarcinomas are driven by a single marker? I mean, you saw that somewhere in the range of 50 to 60% have one. Is it realistic that 50 or 60% have a response like we tend to see with EGFR inhibitor therapy or with Xalkori? And are the other 40 to 50% undiscovered, or are they considerably more complex than that?
Still an open question. We're certainly hopeful that among the group of patients that does have an identified mutation that we can specifically target, that they'll benefit from that sort of targeted therapy. Many of these trials are not yet complete. Many of these trials have not yet been presented, but our initial data would certainly suggest that if you have one of these mutations and can specifically target it, that that's a reasonable strategy. Certainly not a strategy that's yet FDA approved or FDA approvable for anything other than EGFR and EML4 ALK at this point. But I think we'll see a lot more of those data over the next 5-6 years.
If you look at what's happened in the field just the last couple of years in terms of the different oncogenic drivers that have been discovered, you can see that we're kind of finding these small subsets. You know, ALK was 3 to 5%, ROS is about 1%, RET is probably 1%, very similar. These very, very small subsets. My best guess is we're not going to find another oncogenic driver like KRAS, for example, that comprises the 40 or 50% right now where we don't identify something. I think we're going to continue to chip away at it, but it's going to be little slices of the pie.
Chipping at 2 and 3 and 4%
right.
at a time.
The other point I wanted to make was it's a little bit of an oversimplification to think of them as a single driver for this tumor type, because I think even within those subsets where there's a dominant driver, it's clearly a complex tumor, and there are other genomic alterations that are important. Not all EGFR patients respond to Tarceva. Not all ALK mutant patients respond to crizotinib. So there are other drivers, and clearly the phenomenon of acquired resistance is an important one.
And I think as we get into the smoking population, we are going to find that the multiple pathway biology, whereby a tumor is driven by up to 5 or 6 pathways at any one time, is going to be important. Pharmacologically, we're going to have multiple drugs being used simultaneously in order to control some of these tumors. So I think that is certainly a big chunk of that group that is unknown out there. There may still be some low-hanging fruit with these oncogenic drivers, but I think the vast majority of the remainder of the tumors are going to be multiple pathway driven.
Right. Some people have brought up the way that AIDS therapies was remarkably improved by combinations. It wasn't just single therapies, and the most genetically simple cancers can be cut off at the knees, at least temporarily, by one drug, but it may well be that we get more sophisticated and end up having to combine 2 or 3 different lines of attack in one line of therapy.
Or even, you look at examples with CML, leukemia, chronic myelogenous leukemia, or in gastrointestinal stromal tumors, now multiple drugs are in line for sequential use for patients who stop responding. I foresee some of these things being like that. I know Alice and her group are already working on a number of drugs for folks after Xalkori. That's the hope, I think, is that if you can't cure patients, you can convert these conditions into more chronic conditions where hopefully newer drugs come along every year.
We'll continue our discussion in the next podcast. Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.